unusual to have an award as a ROP specialist, but I think I want to thanks Anand and Dimitri for the invitation. It is a very good pleasure to be here because part of my career started here years ago with the Indian organized World ROP in Delhi in 2008, and it was a beautiful experience. And part of the work that I done with Graham in the fluorescence and angiography started in the afternoon in the lobby of the Le Méridien. So it's a very great privilege. Plus, ROP is a worldwide family. We are not so many, and this is important because we are working together, and everybody is more than happy to help who's approaching this problem with their expertise and sharing cases. And now it's very easy with WhatsApp and any kind of way to share images. We are more than happy to collaborate and to give our expertise to the people that is approaching this very difficult pathology. And in terms of fathers, I think that is not working. Okay, these are my disclosure. As Anand said, I was one of the committee in the member in the Firefly and in the Rainbow study. We accomplished the Rainbow, and now we are finishing almost. We are now analyzing the 5 years data on for the Firefly organized by Bayer. Mike Trese, for me, has been like a father because he was the one that really introduced me to the vitreoretinal surgery. As a fellow of Graham Quinn, Graham is a pediatric ophthalmologist. He was, I can tell you because it's not nothing bad, but he was in Centerway competing with Mike because Mike was more in favor of surgery approach, while Graham was more conservative and tried to fix the point of very good screening and very good methodology to avoid vitreoretinal surgery. But when I approached the vitreoretinal surgery, pediatric vitreoretinal surgery with Mike Trese, I found out that it was not so difficult, because one of the characteristics of Mike was really to make simple the very difficult things, like approaching the retinal detachment in ROP. I think that one of the things that inspired me was the way he was talking with patients and parents, of course, because he was very, very patient, trying to explain and make people to understand what was going on. And this was very difficult because talking with parents involved in ROP for their kids is very difficult. People don't want to understand in some way. And he was very patient, was spending a lot of time talking with them and make things simple again. And I put this picture on your right because the main reason why Mike was involved in pediatric ophthalmology, besides on this guy, is a legend in US, is a fullback in the team of the Los Angeles Rams, and is the reason that the guy was so good that Mike lost his position in the team at the Michigan State University football team, and he started to be involved in ophthalmology. If Tom Mack was not there, probably we will have a good football player, but not as fantastic and extraordinary surgeon in pediatric ophthalmology. And another thing I always keep in my mind when I see kids, the same I said monologue that he does when he was seeing patients. Good, pretty good, good. And this, always when I see baby, I always keep in my mind his voice is a fantastic teacher. Just to put together a very long story, he was graduated in the University of Michigan, and he did the OD, the optometry degree before the med school at Georgetown, and the residency at Jules Stein Institute in Los Angeles. So he visited almost all the entire United States, and it was a fellow at the National High Institute, and in particular, Robert McNamara was his the people, the doctor that approached him to the pediatric retinal diseases, and he held a lot of leader position as a director of the vitreoretinal surgery in the University of Kansas, and finally in '82 he joined the Associated Retinal Consultant in Michigan, and in '82, and since that moment he spent his entire life in the William Beamon Hospital in Detroit, and finally he also reached an academic position, becoming clinical professor at the biomedical science in the Oakland University, and a clinical associate professor at Wayne State University School of Medicine. And he was, of course, the head of the adult and pediatric vitreoretinal surgery at the Beamon Hospital in Detroit, Royal Oak, to be precise. The academic achievements are fantastic. One thing that I think about Mike was always in the right place at the right moment. He was visiting Charlie Chaplin when he was fellow of Robert McNamara, and he was in the right place every time in his life. He received the Donald Gass Award in 2013, and the most important award he received was a laureate award of the American Academy in 2001, which is a very rare award that sometimes American Academy give only at a very important member of this society. And in terms of leadership, I like this picture because they were so relaxed, and in Calgary, in Canada, the meeting was organized by Han Els, which was one of his fellow, and it was part of the International Committee of the Second Classification. And among the others, I think that what was inspiring in the last years of Mike was to create a group that is not only taking care of ROP, but also taking care of pediatric retina in general. That's why he pushed Cindy and Amy Hartnett to organize a biannual meeting in US about pediatric retina. And this year there will be in September at Duke University, the APR meeting, Advanced Pediatric Retina meeting. And of course the other idea was to create a society, and probably if we can accomplish this, it will be another way to honor the memory of Mike. So talking about what he did in his life, pediatric vitreoretinal surgery is his main job. He revolutionized the pediatric retina surgery with introducing the concept of lens sparing vitrectomy. I was visiting many years ago Tatsuo Heroes in Boston, looking at the open sky vitrectomy, and it was it scared me, and I decided not to do this in Italy anymore because it was very complicated, and a very important expertise was needed to perform that kind of surgery. What I found when I went to Detroit was that at least it was feasible. Of course, it was a merit of Mike, but because it was not, it's very complicated, but at least less complicated than open sky. And so he did with many others visiting people in his institution. Well, I think someone is here in the audience, and I think we can share with them the same approach, because you can easily understand the people that was trained by him. It can be recognized by the approach that he does, not only with parents but also with the cases that he was dealing with. Another important issue is the classification of the fever, the familial exudative vitreoretinopathy, and the Coats disease. And I think the techniques that he performed helped us to restore the vision of at least 2,000 children 1,000 children. And then the impact that still Mike has in the pediatric ophthalmology experts is very important, and we have to continue the path that he shows us, because that will be the best way to honor his memory. And again, he was also a translational scientist. He was able to to create some instruments. The spatula that we use during surgery is another important creation by Mike, and he tried also some innovation in the vitreolysis, like the ochreplasmin. But what most important, he started to use genetics in the approach of some of the pediatric vascular diseases, and something that now is becoming very popular, because we have a lot of easy instruments to use. It started to apply in that difficult time, studying all the vascular diseases in the pediatric era. But what I want to emphasize more is the work in telemedicine, because it started in 2000, showing us that it was feasible to realize that screening using telemedicine for retinopathy of prematurity. And starting from this paper, Hanels was able to demonstrate that there is a possibility to demonstrate, to have a concept of referral warrant, which means that sending the babies that only need to be treated is important, because you can save money, you can save time, and also you can use less the expertise of pediatric ophthalmologists. I will end time. This is just to be in the timeline of the pediatric telemedicine studies. Started in 2000, and we are still going on. Part of the study is done here by the Indian group, and the concept of referral warrant is the ability to identify the stage that really need to be treated, and it's time saving, and it's also money saving, because you can save a lot of unuseful examination, and also a lot of money that can be spent because of the transfer of the babies towards a treatment center. Starting from that, Mike started another study that was Fodorov study, with the possibility of following the baby during the clinical course of the retinopathy of prematurity, and he demonstrated that the screening done with Fodorov was possible to have a sensitivity of 92%, a specificity of 67%. That means it's very excellent results at the time. Then other studies started. Darius started with the Sandrop, and I was part of the committee. Birgit Lawrence in Germany, Anand in India, Boston, and Mike Chang, of course, started the IROP study that is still ongoing. It was one of the most important studies in the field of the ROP, and the long ROP I did with Mike, and finally also Graham did some study on Europe based on telemedicine. It is one of the most important things about this study. I was part of the committee too. It was that non-physician readers perform much better than experts, because they are completely open mind. If you train them to recognize a lesion, they work very well in their job, and they work better than experts, because sometimes we put our expertise, our thinking in the analysis of the image, and we lose the objectivity of the image. Key drop is Anand's work, and it was fantastic, because it was the first and largest world program to employ non-accredited non-physician to grade and report ROP, which is the direct consequence of what Graham said in his study. And this is very important, because it shows us that it's important to it is feasible to do this kind of screening in middle-income countries, and with very critical demographics issues. Sundrop is another study, is a fancy one because it was done in California and with a lot of money employed. But the important is that we need to be in time. We need to be we need to treat the baby in a very efficient way, and telemedicine can do this. And in particular, he compared the use of digital camera to the biome, to the indirect biomicroscopy, which is still the gold standard. When we started to work on ICROP, and I remember this discussion, we took the idea that we have to refer to binocular indirect, which is still the most important, most common instruments to screen the ROP, while we have to affirm that the telemedicine and digital imaging is unrivaled compared to the biome. And that's what Darius was able to show in these two studies, SUNROP and LONGROP, which is the long-term follow-up in these babies. Because why telemedicine is better than bio? Well, if you look at images, the right you see the bio images compared to the draw that usually Darius does when he's screening in his NICU, compared to the images that you can see the evolution of the disease very well, and this helps you to be exactly on time when you decide to treat the baby. And also, of course, you can realize a composite and any kind of analysis you want to perform on these images. It is feasible. Even teach our students how to treat the babies. It's much more easy when you use this instrument. What you need for telemedicine? We need a digital fundus camera. Hopefully, we'll have a less expensive camera and easy to use in the NICU. We need trained personnel, we need internet access, we need experienced ophthalmologists, and also we need a image management software, which was at the time quite difficult to find, but right now with the artificial intelligence we will see we have instruments that are very powerful. This is a workflow and how to organize a telemedicine screening in ROP, and this is the system that is now in place in California. You have to set a very strict protocol. You need identification of the babies in the NICU, notification to the MD that will take care of the baby as soon as they are discharged from the NICU, the standard photographs, and report generating, and recommendation to repeat the screening as soon as they are discharged. You need to set a mandatory multiple examination schedule, which is part of the entire the work that we have done when we set the new guidelines. A little dilatation is needed to allow to have a good photos, and you have to set a protocol of the image. So you need an external optic center, superior, inferior, nasal, and temporal. And finally, the American Academy of Pediatrics, together the American Academy of Ophthalmology, defined that the use of electronic information and communication technologies provides support healthcare when distance separated participant. It is very well accepted for ROP screening in the US. There are also a company that together with insurance company in US start this safety network focused to create an educational platform in certification for telemedicine screening. And in terms of biomarkers, we will discuss this tomorrow in the other session on ROP. It is important because telemedicine is part of the ophthalmological features that is a direct biomarker of the ROP. And but what is more important is that we need a new algorithm that can help us to manage ROP in terms of enhanced image analysis. Fluorescein angiogram can be realized in different way. Angio-OCT is an example, but artificial intelligence can help us to get the same information from a regular fundus image. The weight gain-based risk prediction model is another important part of the new algorithm that we have to create to manage the ROP in a better way, and quantification of vascular tortuosity in order to avoid the inter-observer variability that we face every day when we look at an image of plus disease. And with this kind of background, the requiring treatment, the efficacy of the treatment will be 99%. So this will be, this is bad news for the vitreoretinal surgeon, because we show that it is feasible to have zero retinal detachment in a controlled way. If you look at the rainbow results in the perfect world of randomized and controlled study, no one got a retinal detachment. And this is very important. If you do the right things, we can avoid the blindness of, from ROP. And again, he was already facing the battle against the pancreatic cancer, and he wrote this paper, The Renaissance of the Ophthalmology through the Artificial Intelligence, because he was a real visionary. He was able to understand what was going on and what will be the future of the pathology he was always fighting. And the artificial intelligence is the new instruments that together combined to telemedicine will help us to reach the 100% avoiding the retinal detachment. And so I can conclude this. The future is here, and if we keep the path that Mike traced for us, we'll have a very bright future for our kids. Thank you.
Thank you so much, Professor Lepore. It's indeed an honor for us, for you to give you this oration, and thank you for giving us sort of deep insight on our common mentor, Mike Trese, and leading the way, and then sharing your experience and telling us where we are poised now for the future of ROP. Thank you once again.
Thank you very much for your wonderful presentation, and I would like you to share us the PPT of your presentation so that we can get more out of it, and we'll discuss in our council meeting about various things you have said, how we can also develop such things, few things which is very attractive and which is very interesting for us. So I hope there is no copyright. Maybe some copyright may be there, but
there will be no copyrights, unless I have to tell you that I mean, the story with artificial intelligence, everybody knows there is some commercial interest, even in getting the FDA approval for the system. And what I want to emphasize that the work we are doing with AIOS is will be completely free, and as soon as we get the authorization, they will be available for everybody without any charge. I think this is important because we need to use these instruments, and we need to be the key. We need to be the key of the use of the artificial intelligence. We don't have to have been submitted from the companies that included the artificial intelligence in their system. We are the doctors, we are the leading, we are the stakeholders, and we have to analyze the data. We are not only the validator, we are the doctors, and this is very important.
Thank you. We have two